Okay, we're good to go.
Wonderful. Thank you so much, Tamara. Welcome, everybody. Welcome to the 2022 Medicaid Transformation Project Public Forum. I'm happy to be here with you today. And I've got a couple of slides to get through here. So next slide, please. Okay, so welcome to Zoom. There's just some housekeeping that we're going to get through here. We are recording today's webinar. So at this time, we've muted all attendees, which means that you can hear us, but we can't hear you. There's going to be a time at the end for Q&A, and we encourage you to submit questions and comments through the chat function. And you can do this during any part of the presentation. You don't have to wait till the end. And if you wish to verbally share your input, you can raise your hand using the raise hand function, and we'll call on you during the Q&A. But kind of approach it like a first come, first served kind of a thing. The raise hand function is under the reaction section of Zoom, if you're not familiar. And there's a little image there that hopefully can help you. We also ask that you please keep your video off unless that we've called you to ask a question or to share a comment. The slide deck from today and a recording of today's webinar is going to be on our MTP meetings and materials page. And it takes about a week or so to post the recording, but it'll be available mid-December. Next slide, please. All right, so first off, I want to thank all of our presenters for being here today. And I also want to thank our behind the scenes folks. Tamara Henshaw, Julia Wilson, and Addie Augsburger. Thank you so much for being the support behind the scenes today. So this morning, we're going to hear from Michael Arness, and he is the Deputy Policy Director here at Healthcare Authority, or HCA. We'll also hear from Chase Napier, who is our MTP Director, and MTP stands for Medicaid Transformation Project. We have Kathy Kinnaman, who is the Home and Community Services Director for Aging and Long-Term Support Administration, also ALSA, and that is a part of Department of Social and Health Services, or DSHS. We also have Matt Christie, who is our Foundational Community Supports Administrator here at HCA. We also have David Johnson, who is a Federal Programs Manager at HCA. And I am going to be moderating today and kind of walking us through the Q&A and resources and some other slides. So, and my name is Rochelle Alonji. I'm the Policy Communications Manager here at HCA. Next slide, please. Okay, so a quick run through the agenda. We're going to be doing an intro to MTP and summary of programs. We're going to do talk through the 2022 successes and challenges. We are also going to talk about the MTP renewal, which we're calling MTP 2.0. We are going to discuss an update on MTP 2.0 and kind of where we're at with negotiations with our federal partners. We'll talk about some resources, and then of course, the most important part, we'll have some time for Q&A. All right, next slide. Okay, Michael, I believe you are up, so I'm going to pass it to you.
Thank you, Rochelle. Good morning, everybody. Michael Arness, Deputy Policy Director. And this morning's discussion on Medicaid Transformation Project is all about the partnership that our state has with our federal partners at Centers for Medicare and Medicaid Services to propose new policies and new programs for the state's Medicaid program. And so let's talk about on the next slide, starting with the 5 initiatives that we have. And I'll just introduce them briefly because people will go into depth in the next few slides. But MTP has 5 initiatives, and the first is Initiative 1, where we work with accountable communities of health and Indian healthcare providers to implement projects that really improve how we perform healthcare in the regional areas around the state. And then the second is long-term services and supports, and those are 2 innovative programs that are really part of the state's initiative to move from institutional services into residential services. And Kathy Kinnaman will talk a little more about that as we go forward. And then foundational community supports, again, helping vulnerable adults in the Medicaid program maintain stable housing and employment. And Matt Christie will talk about those 2 innovative approaches as we go further. On the next slide, tomorrow, we've introduced a topic that David Johnson will delve into a little bit more, which is about institutions for mental diseases. And these are services that are performed at particular institutions around the state. And in particular, we wanted to make sure that we had some federal and state payment options for substance use disorder treatment. So you have the SUD, IMD, and then mental health IMD. And what we've done is partner with our federal colleagues to have a different way of paying for these services if we also committed to some quality standards as we went forward on that. So a good partnership there that David will go into a little bit more. So with that, let me hand it right on over to Chase to talk about Initiative 1.
Thanks, Michael. Yeah, again, folks, I'm Chase Napier with the Healthcare Authority. I'm the director of the Medicaid Transformation Project. And yeah, I want to talk a little bit about some of the work on Initiative 1, which is our Delivery System Reform Incentive Payment Program. I know that's a mouthful. It's a DSRIP for short. And if you aren't familiar with the structure of our program, we've worked with our 9 accountable communities of health across the state. They're in 9 distinct regions that span the entire state. Every county, every community is represented within one of the ACHs. And they're really a multi-sector collaborative for bringing partners together, healthcare partners, community-based organizations, community voices, tribes, and many other important partners to collaborate on delivery system reform and innovative projects to really improve the health and wellness of our communities. And so just to highlight just a few successes here, we had 8 project categories really, ranging from bidirectional integration of care to community-based care coordination, transitional care, diversions, addressing the opioid crisis, maternal and child health, access to oral health services, chronic disease prevention and control. So just a lot of really important work in those project categories. And over $545 million has been distributed to date from the start of this program through, I believe it's the end of September is our latest data. So this is actual dollars going to partners and community organizations and providers to support their capacity building, to support some of these innovative projects in those categories that I mentioned. There are over 780 partner organizations that have received funding, and there are many others that have received technical assistance, have been engaged in new partnerships, new ways of collaborating and working across communities and across sectors. So that's just a smaller representation of the real broad impact of the partnerships that have been formed. And then we've really expanded our focus on health equity. Health equity is a goal that was listed in our original waiver application, but it's just been, we've learned, we've continued to learn and continue to grow. And our ACHs have really led this journey on health equity and increasing our focus on training and education and investment that really is from an equity lens. And then there's a cohesive effort. Really, we've done some testing on community-based care coordination. And really what do we mean by that is we mean the connection to all of the important social services and community supports beyond healthcare coordination. So we're really thinking about the needs that exist outside of healthcare and how critical it is to be able to make referrals, to be able to identify what those needs are and address those needs, and then to make sure that when we make a referral to some of those programs in the community that we can confirm that the services were provided and that the outcomes were achieved. So there's really a renewed energy across our state on a cohesive model for community-based care coordination, and we'll talk about that later on. Challenges. So workforce has continued to be a challenge through the entire project, really, and we've done some really great work, but there's more work to do, and some of that, of course, has been influenced by the pandemic and some of the COVID impacts. And so there is just that ongoing work to address some of those impacts that are really extend beyond workforce. And ACHs have worked with partners and collectively, I think our system has done a really great job of responding to COVID-19. But we're seeing still some of those impacts and continue to work to address and mitigate. And then there's obviously some ambiguity with the transition from what we're talking about here with the delivery system reform incentive payment project and the categories of work, and then transitioning from that to a new body of work under MTP 2.0. And especially as we negotiate that with CMS, there's just some uncertainty and some ambiguity. And so that right now is something that we're working with our partners to look ahead and really create a shared vision as much as we can with our partners. And as we wrap up those conversations with CMS, of course, we'll continue to work really closely with all of our partners on the journey ahead. So with that, I am going to hand it over to Kathy.
Hey, good morning, everyone, and welcome. My name is Kathy Kinnaman. I'm the new HCS director, and I'm going to talk a little bit about Initiative 2 and then ALTSA's response on Initiative 3 around foundational community supports. So I'd like to brag a little bit about the accomplishments with our MAC and TSOA programs. This is Medicaid alternative care and tailored supports for older adults. And these are programs that are really there to support family caregivers in the care that they provide to their family members. And so as of mid-November 2022, we've served almost 14,000 care receivers that have been served since September of 2017. And that doesn't take into account the caregivers that we're serving as well. Our client satisfaction survey showed that 83% of our clients were actually very pleased with the services, and we had some really great stories come through, in that survey around just the impacts that these programs have made in people's lives. We've delayed and diverted care receivers from needing more intensive and costly long-term services and supports programs, which has saved both federal and state dollars. Although, our clients can obviously transition to our programs at any point whenever they need to, and we try to make that easy for them to do that. Our 2022 quarterly reports to CMS demonstrate that ALTSA and our Area Agency on Aging partners have exceeded proficiency requirements in all of our quality measures, which is just impressive information considering the breadth of the network that we serve. And then we've also worked with partners to improve the translated Spanish version of the TCARE caregiver assessment. And that's the tool that we use in order to determine the services and the level of services that folks would need to receive under these programs. We can go to the next slide. So moving into foundational community supports, this is our Initiative 3, and it has two components for us at ALTSA. There's a supportive housing component and also a supported employment. So under our supportive housing, we're currently serving 1,276 ALTSA clients, and that was most recently updated with August data. 76% of ALTSA clients identify with some kind of serious mental illness. And then 66% of non-ALTSA clients in supportive housing also suffer with serious mental illness. So the ability to get them into, a supportive housing and secure environment is so important. From July through September of 2022, ALTSA provided 82 provider technical assistance sessions and 15 regional or statewide trainings for our foundational community support services and supports. So our trainers have been really busy out there, making sure people have the information that they need. We go to the next slide. So supported employment, we're currently serving 900 ALTSA clients, again, as of August. A significant portion of those clients identify as having a serious mental illness, 81% in this case. And we have found that ALTSA clients tend to utilize the services at a higher rate than our non-ALTSA clients. So at some points up to 11% higher, with an average of 7.6% higher since September of 2021. So some preliminary findings based on client analysis, which was completed in September 2018. So it's a little bit out of date. So we need to get that updated. But what we have been seeing is an 8% employment increase for ALTSA clients, which is incredible. And then I think more importantly, that we're seeing increased earnings for those clients, per quarter. So, $200 may not seem a lot of money, but, when you're, very low income, being able to have that extra money coming into your household is just so important. And then our ALTSA employment team provides foundational community support, supported employment, and also benefits planning trainings. And they've provided those to over 750 individual ALTSA and area agency on aging staff each year. So again, that team's been really busy making sure that information is out there to support, our staff and AAA staff being able to connect people to these important services. We can go to the next slide. So some of the challenges in 2022, I think across all of these initiatives, you're going to see like COVID-19, that hampered some of the outreach efforts just in general. But for MAC and TSOA, we're really facing problems with our provider shortage. So it's difficult for us to get providers for respite and personal care just because of that, which is a national issue. We also find that our clients struggle with social isolation. And we've put various initiatives in place to help that, but that's always just been something that is hard for us to deal with and for our clients to deal with. And then in 2022, we implemented the use of the Consumer Director of Washington. And so, that's been a learning curve for us all as we've transitioned our individual providers over to that new employer and making sure that they were able to get enrolled and registered and be able to get, caught up with all of their trainings and those types of things. I think from supported employment, some of the challenges are provider shortages, travel costs for providers to serve clients in some of our rural and hard to serve areas. And then just that coordination, it's such a massive program, with just many different pieces to it. And so coordination with those subject matter experts in order to make those decisions around the programs and the best way to move forward on those. And on supportive housing, it's probably no surprise to anyone that there's, we always struggle with a provider network capacity, to be able to get folks into housing. And then, we don't have enough of the rental subsidies that we need to pair with our services. And that's so important. The governor's opportunity for supported housing, has just been such a key piece in terms of those subsidies being able to be there and help people with the rent portion. And again, just that whole coordination issue is sometimes difficult with these programs. But, in general, I would definitely say that the successes far outweigh the challenges. So with that, I'm going to just turn this over to Matt Christie, and he's going to talk a little bit more about foundational community supports.
Great. Thank you so much, Kathy. And yes, just picking up off of where she left off with the foundational community supports program. Just a real quick introduction. I'm Matt Christie. I'm the supervisor of the FCS team here at the Healthcare Authority as part of the Division of Behavioral Health and Recovery. One of the big things that we'd just like to highlight is, and this number is even out of date, but we've almost served 30,000 individuals since the program launched in 2018. We got a year late start compared to the rest of the waiver, and our protocols and terms and conditions of our program weren't approved until late 2017. So a year late start, but we really hit the ground running since then. We've built a provider network of over 175 contracted providers with more than 450 locations statewide. So this is a statewide benefit with quite a unique provider network. Some of the, I would say, challenges and opportunities are around that provider network that I'll get to in a few moments. But our provider network has a lot of different non-traditional to the Medicaid world providers, I would say, including housing authorities, community nonprofits, and other community-based organizations doing this work of supportive housing and supported employment services. The program has seen a significant amount of investment in recent years. Some of the things that we're currently working on, like the transition assistance program, that launched back in May has already served over 750 individuals. And the Transition Assistance Program is a state fund that's paired with our supportive housing service, used as a flexible funding source to pay for short-term needs that can include things like first and last month's rent, deposits, non-refundable fees, as well as arrearages and basic home goods. So just since the month of May, over 750 people have benefited from this new investment, which is really exciting to see. We've also received funding to expand our supported employment benefit, and one of the target populations who are eligible for that service are individuals who are receiving the Housing and Essential Needs benefit. If they have a referral for HEN, they're automatically eligible for FCS supported employment. And we received some funding to expand the rental assistance. So it's kind of a joint effort with the Department of Commerce to increase how long someone can receive their Housing and Essential Needs rental assistance as soon as they start earning income above the threshold that traditionally terminates their eligibility for that program. So as Kathy mentioned, we've been seeing statistically significant increases in wages earned and hours worked among all of the target populations in FCS, and especially related to those receiving rental assistance that's tied to their income level. It's really important that we made sure that we had some sort of pathway to employment that didn't jeopardize someone's rental assistance and needs around housing. So it's a great project to be implementing this year. A lot of you are familiar with House Bill 1866, also known as Apple Health and Homes. And this is another really exciting opportunity to partner with the Department of Commerce on really pairing housing with FCS supportive housing services. So if you look at what we like to call as the legs of the stool for affordable housing, you have three legs. You have the capital funding to pay for things like rent, you have bricks and mortar housing, and then you have the support services. And when those are paired together, we really see strong outcomes in housing individuals and transitioning out of homelessness. So a really exciting opportunity that will launch in 2023. And I just want to mention some of the other efforts that we've done throughout the program under the successes. I don't have numbers up here, but just off my notes here, just this year in terms of the technical assistance we've provided out the community, each quarter we do, or each month we do roughly 120 trainings, webinars, regional presentations, conference presentations, and we've reached almost 8,000 people this year with our training and technical assistance. So these are providers, these are stakeholders, maybe providers who are interested in becoming an FCS or starting an FCS program. And so just to give you that scope, we also have implemented a really strong collaborative around our evidence-based practices with our fidelity reviews. And just this year, we've trained over 750 people on those fidelity reviews and completed 30 reviews of different agencies. And a fidelity review is really how close to the evidence-based practice of either permanent supportive housing or individual placement and support for that supported employment benefit, how well providers providing those services that we use to measure our outcomes for the program. So a lot of work that has been done to get this program running, and again, just hit the ground running since 2018. Some of the challenges, and I'd like to say opportunities, maybe more so than challenges, just because these are things that we've consistently worked on over the past few years. And one of them that we like to talk about is how to shift to billing for Medicaid. I guess it's really the first two bullets are kind of go hand in hand. But for our providers who are not traditionally your Medicaid billing provider, how do you shift to billing Medicaid for support services? It's kind of a new world of health insurance for a lot of providers who don't traditionally use this system for billing. And with that, I think the culture shift for supportive housing services as well, using Medicaid as a funding source for supportive housing services that are traditionally funded through federal grants, private investment, and things like that. Really hoping to continue to work with providers, even on a one-on-one basis, to figure out how we can implement an FCS supportive housing program with their, if they operate a housing units, and figuring out ways that they can bring in this revenue stream to balance the funds that they use to pay for housing. The last opportunity, I think, and we have started working on just really seeing more increased collaboration with inpatient treatment facilities and the work that we're doing to help bridge people back out into the community with our support services. And that is my part. And I will pass it off to David Johnson.
Hey, thank you, Matt. David Johnson here. And I'm going to be talking about initiatives 4 and 5, which deal with behavioral health services in institutions for mental diseases. So these initiatives allow Medicaid dollars to be used in IMDs. And IMDs are basically facilities that has more than 16 beds that specializes in psychiatric care. That would be a facility where greater than 50% of the patients are admitted to receive psychiatric care. Those facilities have been considered IMDs, and since about 1965, Medicaid programs have been prohibited from using Medicaid funds in IMDs if the individual is between the age of 21 through 65 years. So we've had to use state dollars for those services, etc. So this allows us to deploy Medicaid funds to purchase services in IMDs for stays of no more than 60 days. If the stay lasts longer than 60 days, then yes, it becomes a state-only stay. So this has saved the state nearly $10 million in state-only funds so far. As part of the overall agreements with Medicaid, this promotes increased access to care in both inpatient and outpatient settings, and it underscores our commitment to increase quality in IMDs and greater access to care in community settings. So next slide, please. So some of the challenges, again, I'm going to be kind of a broken record here and say that the pandemic has added stressors to both individuals and providers alike. You know, it's increased the challenges for the provision of inpatient services. It's added additional variables to required evaluations as part of the 1115 waiver demonstration process. Generally, we have evaluations and metrics that we report to CMS on the success of programs or what we're realizing about the outcomes of programs. And this has certainly added chop to those variables, et cetera. And overall, the pandemic has worsened shortages in the workforce. And to address those shortages of providers, et cetera, the legislature, for example, has made approximately $100 million available in provider relief funds and workforce stabilization funds for behavioral health agencies. And the distributions of those funds just got underway in late September of this year. So, all right,
over to me, David.
Back to you, Michael. Sorry.
Yeah, we're going to transition everybody and talk about the MTP renewal. And our federal partners at Centers for Medicare and Medicaid Services allow us to renew the waiver for up to 5 years and to continue a lot of the programs and to recommend some new policies and programs. So we did submit a renewal application to our federal partners in July, and we called that MTP 2.0, which really reflects that we are going to continue with a lot of the current programs and then expand into some of the some new programs. I'm going to talk a little bit about the changes that we'd like to make to our current programs. And then in a couple slides, I'm going to hand off to Chase to do a deeper dive into how we're changing our work on Initiative 1 and calling it Taking Action for Healthier Communities. So on the next slide, I'm going to talk specifically about the long-term services and support. And this is 4 very innovative approaches that Kathy Kinnaman and her crew have come up with to help with the transition from actually 3 of them help with the transition from institutional to residence. Let's go over those because there are 3 things that sometimes stand in the way of somebody transitioning from institution to a residential service. And one is rental subsidies, which I think just stands on its own. Someone needs some help getting into a residential area and then able to receive those services. They need the subsidies. I'm going to jump over coordinated personal care quickly, but guardianship and decision-making supports is sometimes the one thing that is halting somebody from making that transition to a residential area. And then presumptive eligibility, which is a lot broader, but it does help with this transition. But a lot of times the client and the provider can pretty much presume eligibility will occur. Now, eligibility does have to be confirmed, but we can presume it at such a high level that we might as well get the service underway and get going. And of course, with what Kathy was talking about with the earlier programs, the MAC and TSOA, we've seen presumptive eligibility work extremely well. On the second point there, coordinated personal care, it's actually a nice idea that our partners at DSHS have come up with, which is that if we have clients living near each other for whatever reason in the same building, it makes a lot of sense to be able to have someone available, one of the providers available to all of them, because sometimes someone needs just to be checked in on, other times they need a longer visit. And what this coordinated personal care does is allow that one provider to serve many people within an area that they live near each other. And so this will provide a lot of support for the aged, blind, disabled adults and really help with receiving home and community-based services. But then next is that I want to talk about foundational community supports on the next slide, and then a little bit on the IMDs that David was just talking about. So with Matt Christie and the group at Foundational Community Supports, we want to do 2 things that will expand eligibility. So the program will continue to work pretty much as it is, but for the supportive housing services, we'd like to expand the age requirement by taking the age down to 16 and older. And so this will help transitional age youth receive these supportive housing services. The age is at 18 right now. We just need to lower it down to 16. And then the other one has to do with eligibility that's expanded to recognize exiting from correctional facilities so that we can begin these services immediately when somebody's on parole status. And then finally, within the substance abuse disorder for the Institution for Mental Diseases, we wanted to recognize contingency management. And this is in recognition of certain techniques that work with certain non-medical drugs or stimulants. And it's a proven technique. And so we'd like the opportunity to work with our federal partners to expand that within the programs that David is talking about. So with that, what I'd like to do is hand it off to Chase so he can take a deeper dive into the program that's replacing Initiative 1, which is Taking Action for Healthier Communities. So Chase.
Thanks, Michael. Yeah, and the program I talked about earlier, TSRIP, is a time-limited program. And so part of our agreement with CMS was that that would be a a one-time project for capacity building and delivery system reform investments. And as we went through that project, we really did see an opportunity for a focus on health equity and a focus on health-related social needs. And some of that work did start over the past few years, but really wasn't the initial focus. And so as we look at closing out the district program and proposing the next body of work, that's what we are doing with the Taking Action for Healthier Communities program, and really thinking about health-related social needs, as I mentioned. So the 4 components that we're focusing on within the TALK program is developing and implementing community hubs in each of the 9 ACH regions, establishing the broad delivery of health-related services, so really increasing the access and payment for health-related services, some of those social needs and social determinants that can be addressed through Medicaid payment. A greater emphasis on health equity. Obviously, this is not the first time we are talking about health equity, and I highlighted the important work that's been growing on health equity across our state. And then expanding community-based workforce. And there's a connection there to the community hubs. And we'll talk a little bit more about that in a second. But also, you'll see in our application, we have a legislative directive on pediatric primary care community health worker pilots, where we're placing community health workers in pediatric primary care settings, and we're seeking federal match on that initiative to increase the program and increase our ability to pilot and place community health workers. And then there will be evaluation, of course, of that model. So on the community hubs, I mentioned earlier what we mean by community-based care coordination or community hubs. It's really about resource identification, referral to available resources and programs, and being able to track those referrals, being able to support the community-based organizations and the community-based workforce that's necessary to help with referrals and outreach and navigation. And there's also obviously infrastructure, technological infrastructure and other infrastructure. And so we're proposing that this is where community information exchange really can be the foundation for that infrastructure for the community hubs. And the community information exchange is pretty comprehensive. We're not going to fully unpack that today. There will be more resources we can share. But in simplest terms, it's really the technology infrastructure for partners to be able to identify available resources, to make referrals, to understand the needs of the individuals that they're serving, to understand what other programs the individuals are engaged in, to understand if referrals are successful, if services are being accessed, and if needs are being addressed. So it's really that continuity and that information exchange and that resource and referral process. And it's focused really on the social services in the community, the community setting, more than on healthcare coordination. And there can still be some connections. You know, obviously somebody might need to be referred to a provider, a primary care provider, for example. But really, community information exchange is trying to solve the other side of the equation, which is all of the social services and social needs that often are overlooked or unaddressed. And so also, obviously, we are going to be working with tribes and Indian healthcare providers on a similar focus. And, you know, we've proposed a statewide native hub. I think there is probably going to be a lot of similarity on the focus on addressing health-related social needs. The implementation, you know, may look a little bit different than the 9 community hubs we envision across the 9 ACH regions, but we are going to support investments with our tribes and Indian healthcare providers to make sure that we provide similar infrastructure, similar focus on health-related services. So with that, let's see here. I'm going to go to the next slide. All right, so a few other new proposed programs. Continuous Apple Health enrollment for children. And so this is, each of these three is really about continuity of coverage, which is so important for access to services and continuity of care. And so the first one would allow Medicaid enrolled children in Washington with certain income requirements to remain enrolled in Medicaid until the age of 6 without any disruption in coverage. And we're really excited about this program. We know CMS is also really excited and supportive. The second one here is reentry coverage for continuity of care. And this would be to ensure that individuals exiting a correctional or treatment facility do have healthcare coverage. And so what we've proposed is coverage 30 days prior to that planned exit and release from a correctional or treatment facility. So it would allow us to establish that care coordination and planning ahead of that release and exit. All right, and then the third one here, Apple Health postpartum coverage extension. So this would make sure that people who have been pregnant would remain eligible for Medicaid coverage until 12 months after their pregnancy ends. And this would be regardless of citizenship status. And this postpartum coverage did begin through the American Rescue Plan Act. And so what we're looking to do is use the 1115 waiver authority to make sure that postpartum coverage extension can continue into the future. One more program on the next slide to highlight is the Washington Integrated Care Assessment. This is basically a proposal to continue to support through 1115 waiver funding the assessment of clinical integration. So we've had a large focus over the years on integration between behavioral health and physical health care. We know there's more we can do to support providers in that journey and to support the assessment and related technical assistance and coaching opportunities. And so that's what this program represents. There's a standard assessment that's been developed through a work group over the last year. And it's called the Washington Integrated Care Assessment. That's the standard tool that will be utilized. And we're looking forward to supporting assessment and supporting the healthcare community in technical assistance and hopefully some resources and coaching. So let's see here. I think it's back over to Michael on the next slide.
Thank you, Chase. I'm right now just going to provide a quick update on the process of negotiation with our federal partners at the CMS. And as I mentioned earlier, we submitted in July, what is known as an application for renewal of the Medicaid transformation project. And we began active discussions or negotiations in October of this year. And so we are quite certain that we are not going to finish those negotiations by the end of this year and then start MTP 2.0 at the beginning of the year. So what CMS has done is they've approved a short extension for us all the way through June 30th of 2023. And what this means is that we will continue to operate Medicaid transformation project for 6 more months, January through June of next year. And that will be the 5 initiatives that we talked about. At the same time, we will continue those negotiations of all of the items that we submitted in the renewal application, which is about 20 innovative policies or program changes. These are the ones we talked about specifically for the current item in Medicaid transformation project, or some of the larger changes that Chase talked about just in the last few minutes. And so again, we'll run the current program while we have time to negotiate the new version of MTP 2.0. So on to the next slide, just to talk a little bit about what to expect. So we may receive some approval from our federal partners at CMS before June 30th. And if we do, we'll put some of those into place For example, if they are the policy changes to the current initiatives we've talked about, we'll let people know about those and when they start. But we also anticipate that a lot of the major changes will likely come right about mid-2023 of next year. And that should then conclude a lot of our negotiations and our agreement with our federal partners at CMS about how we will operate Medicaid Transformation Project 2.0. Then looking forward after June 30th, we can anticipate that a lot of the programs and policies we've talked about today will be phased in over the 5-year approval of the MTP 2.0. So we know that some of the things that some of the new innovative policies or programs that we're recommending will take us longer to put into place, sometimes a year or two. Others, sometimes an innovative new policy, say with a current program, can begin much sooner, within a few months. So all of that to look forward to. We'll continue to operate MTP through June 30th of next year. We'll implement some policies that are approved before that, but we anticipate certainly a larger chunk of policies and program innovations to be approved about mid next year. So with all of that, Rochelle, let me hand it off to you for something about where a little bit on resources and probably some Q&A.
Thank you, Michael, and thank you to all of our speakers. Very helpful information, and we are receiving some really thoughtful questions. So continue to send those our way. Really quick before we get into the Q&A, I want to cover the MTP resources. So we have a dedicated website section to the Medicaid Transformation Project work, and that URL is right there. We also have a renewal page for MTP 2.0. There is a ton of information on that page, including the full application, all the appendices, and some fact sheets and some other resources and materials that can help you just learn the more of the nitty gritty about the renewal. We also have an FAQ, a frequently asked questions about MTP 2.0. It covers a lot of what Michael just shared, but a few more nuances. So that's available there too. And then of course, we encourage anyone and everyone to sign up for our announcements via GovDelivery. And we send those out to folks who subscribe, and we send regular communications out about our efforts with MTP and all of our initiatives. So with that, let's go to the next slide. And time for Q&A. So we've got just a little over 10 minutes. We have a lot of questions we've received. And so what I'll do is I will queue up the question, and then we have a subject matter expert that's on the line, likely one of the presenters from today that can answer that question. So bear with us. We have a lot of stuff going on behind the scenes, but we want to get through as many questions as we can. So let's start up at the top here. And let me see here. Yes, and the copy from today's slide deck is going to be available on that page that Addie shared. That's our MTP meetings and materials page. And then let's see here. Andrea, I'm interested in hearing more about the evidence of effectiveness of the Care Coordination Initiative supported with clear primary and secondary data measures. How is HCA or Healthcare Authority accounting for linkage and referral services offered by other evidence-based care coordination models, also serving Apple Health members? And I believe we have, oh my goodness. Do we have I've forgotten, I've with the back and forth on behind the scenes, Michael, was that going to be going to you?
Yeah, let me start. And I think
Okay,
others such as Jason and Kathy can certainly add wonderful insight. But this is a wonderful question because we all know that there's a tremendous amount of medical care coordination that is being performed, as well as community-based care coordination by accountable communities of health and others within regions, Rochelle. So yes, there does have to be more coordination on that, and we're taking that into account with how we propose the MTP 2.0. We're working closely in a task force with the ACHs as well as representatives from the Medicaid, our managed care organizations, the MCOs, and also working closely with combining our colleagues from Department of Health, as well as Kathy Kinnaman and other colleagues from DSHS into there, because we know that we have the area agencies on aging as well. We do need to coordinate better on care coordination because of so many good care coordination activities out there, and then find a way to blend it with community-based care coordination. And so we have our sights set on that for MTP 2.0. So Chase, if I could hand it off to you, anything to add there, and Kathy may have some wonderful insights as well.
I'll just be really brief, Michael, and just reinforce that we see the community hubs as filling gaps where the gaps exist, and then otherwise just helping to provide continuity. So we do agree that the connection to existing programs and models is really important. This isn't meant to be the one size fits all. It is a gap filler and can actually, we believe, provide more continuity across those programs at a regional level, trying to make those connections and create some of that shared infrastructure.
All right, thank you both. All right, the next question we received, I'm interested in hearing more about the evidence of effectiveness of the care coordination initiative supported. Actually, sorry, let me bop down to the next one. Question number 3. I'm wondering how other partners like Department of Health or DOH, where I work, can help some parts of this work to free up more of this funding for supported housing. And then regarding workforce, we would love to help with transitioning of non-physician team members on diabetes and cardiovascular disease management and prevention. Matt and Kathy, can I pass that off to you?
Well, maybe I could go ahead and kick it off. This is Kathy. And then just really maybe focus more towards the supportive housing piece. Because I think this is a combination of like the federal funding that we get through the foundational community supports and through the 1115 waiver. You know, it really helps provide those wraparound services to help people maintain housing, you know, once they've got into housing. But the piece that we find is missing a lot is actually being able to pay the rent itself. And Medicaid and the federal dollars have never been allowed to be used to pay for rental subsidies. And so the subsidies that we do have are very limited, and they're being paid for out of state dollars that were appropriated to us. You know, so, you know, any way that we can kind of get some, you know, eyes on this problem, you know, we're asking for additional funding for those subsidies, you know, hoping to see what might come out of the governor's budget when it's released next week, hopefully. But any ways that we can get to have more of those subsidies available would obviously help with this issue, because, you know, you can only go so far with the supportive housing if we don't have the funding to be able to help with the rent in the first place.
And this is Matt Christie with Healthcare Authority, and just following up with what Kathy mentioned about rental subsidies, we are also seeking federal approval through CMS for transition costs and rental assistance under the waiver, similar to what has been recently approved in the states of Arizona and Oregon and California, offering short-term rental assistance for eligible individuals. And then just regarding partnerships with Department of Health, we have partnered quite a bit on topics like licensing around different types of housing. There can be a lot of gray area between types of housing and what requires licensing, things like that. There's a newly formed team at DOH as well, focused on homelessness and housing that we've begun meeting with, and just looking forward to more partnerships as we move into the second phase of our waiver.
All right, thank you both. Okay, next question. I know there's a procurement that I think is still being considered to create a pro bono counseling network. It was approved by the legislature in March, but still haven't heard if it's being released this year or next. Wondering if there might be some more information on that coming soon. Thanks so much. All right, so when that question was asked, we did a little bit of digging on our site to see what we could find. There's no status information, but we will be looking into that and seeing if there's anything new from the ledge. So thank you very much for the question. The next question, I believe, is for Chase. In the early days of the Medicaid transformation project, some of us were involved at the Accountable Communities of Health, or ACHs, in supporting the development of a statewide data dashboard that would be at the detail level of being able to actually track and use analysis of the data to measure the performance of services and programs being offered throughout the state. This dashboard to be available at the HCA level, available to the public, has the system been put into place, and how might we be able to access information? Are there periodic summary reports that are published that provide a snapshot of how things are going at a point in time? So Chase, there's a lot to unpack there, but I'll pass that off to you.
Yeah, I think to be brief, I think we can share quite a few resources that cover all of those questions. There is a state data dashboard, Healthier Washington dashboard, that HCA's analytics research and measurement team manages, and there is some lag. I know there's a question around timeline of release later on, and there is some lag, and there's some explanation around the reason for that lag and the data maturation process. But yeah, there's the dashboard that is live, it is updated, and it has a couple of cool features, so we can share that. And then there are other reports. We do a statewide accountability report to CMS that covers just a subset of metrics and accountability that we have to CMS. There are rapid cycle evaluation reports that cover a broader set of metrics and provide some real-time insight from our evaluator. So several resources we can share.
All right, thank you so much, Chase. And I'm just keeping an eye on the time here, and I also see a hand raised. I know we've got some questions in the queue, but I also want to have the chance to have Amanda Bird-Skookum be able to ask a question. So Amanda, can you unmute? And you're welcome to turn your video on or not, up to you. We'd love to hear your question.
Hi, so we offer supported employment, and we've had a few clients come to us who are receiving services from HEN and have received the message that they should not work and not enroll in FCS supported employment. And I saw that in the presentation you'd mentioned something about, I just wondered if maybe you could expand a little bit about the HEN as far as not excluding FCS supported employment and still being able to receive benefits.
Hi, Amanda, this is Matt again with Healthcare Authority. Thank you so much for that question. And that's exactly kind of the space that we are working in, really trying to remove those disincentives around going back to work. This funding is new as of this past legislative session, so we're still in the early phase on implementing this proviso. But what it's really geared to do is twofold. So creating a bridge period for up to 9 months of additional rental assistance for those individuals who are receiving HEN, Housing and Essential Needs rental assistance, who are going back to work through FCS supported employment, my apologies. And the funding also includes things that we're going to roll out, such as benefits planners that'll serve each region, as well as supported employment specialists to help people navigate really that, how do you transition off of your HEN benefit once you go back to work? So really spot on question, and I think more information coming on that. And if you want to follow up with me or send me an email, I can send you my email address, and we can connect you with more resources. And we have some other people we can connect you with as well.
All All right, thank you so much, Matt, and thank you, Amanda, for the great question. So we are right now at time. There was a lot of other questions we were not able to get to, but I am putting in our Medicaid transformation inbox email. Please reach out to us if you've got some questions. If we weren't able to get to those today, please email us. We would love to continue to engage with you and answer those questions and comments that you may have. So real quick, let's go to the last slide. And just thank you all so much for spending your morning with us. Again, we are going to have this recording and this slide deck available on our website. Our email is there. It's also in the chat, medicaidtransformation@hca.wa.gov. Thank you so much. We appreciate you. And thank you again to all of our presenters and our subject matter experts and those people behind the scenes making this happen today. Thank you. Have a happy and healthy holiday season. So we'll see you very soon. Thanks, everybody.
Thanks, Rochelle.